And Erica has worked as an OT for 24 years, some with adults, but 17 years in pediatrics, doing inpatient. She's also done outpatient human health, excuse me, I always want to say human, outpatient home health, and in the NICU. She's passionate about family empowerment and creating positive feeding experiences. She's also an international board certified lactation consultant, which helps support optimal feeding practices in working with her patients. Ruth is a lactation consultant at UC San Diego Health and also an instructor at the UC San Diego Extension Pathway to IBCLC program. And Ruth specializes in maternal and child health, offering guidance, encouragement, and support with breastfeeding and lactation. She's been a registered nurse for 30 years and is also an IBCLC. She's been IBCLC certified for 20 years. Her expertise is with fragile and premature infants and infants with cardiac diagnoses, but she's experienced with all newborns beginning their breastfeeding journey and the common challenges they can face. She also specializes in perinatal mental health and has earned the perinatal mental health certification. So we're looking forward to hearing from Erica and Ruth today about the We Nuzzle program, which is a quality initiative that's developed at UCSD to promote non-nutritive breastfeeding and preterm infants. So if you are ready, you guys can take it away.
Thank you. Erica's in charge of driving the slides.
Yes, here we go. I started talking. Classic mistake. Okay. All right. So thank you guys so much for having us talk today. And we love meeting and talking and collaborating with other institutions and other professionals from all over. So this is really awesome. So essentially, quick introductions, which have already happened. Ruth, do you want to take it?
Yeah, thanks for the bio, Claire. That sounds old when you've been working for 20 to 30 years, you know. I wanted to say personally, first, this is my family. This is my husband and other loves of my life, my 2 grand boys. We have 6 children together, 2 of our children are married, so that's 8. And then we have our grandbabies. They live in Vegas, and I'm excited to see them this weekend. So that's fun. Even though it's close, it's hard when you're working. So that's my personal life. I'm a Californian through and through, lived here my whole life, love San Diego. And professionally, I worked at the local children's hospital here in San Diego, and I had done per diem lactation postpartum at UCSD, and then I had left, and then I came back in the NICU, and I just love working at UCSD for so many reasons. And I'm excited. I've been here almost 8-9 years and just love working with the moms. As Claire said, perinatal mental health is also one of my passions. I feel like if you don't have a mom or a family who is taken care of mentally and other reasons and how they're doing in the NICU, you can't really work with lactation with them. So that is really one of my passions too, is the family dynamics as well as breastfeeding and lactation, and especially in the NICU with babies who are, special needs or just parents are traumatized by just things that we wouldn't even think. So that's what I love to do. And I love working with Erica. We joke we're our work wives because we just work so closely integrated together. And it's just amazing what I've learned from her too. So thank you.
Thanks, Ruth. And then myself, this is my family here, my husband, Mario, and my son, Soren, whose first day of school yesterday, 4th grade, 9 years old. And he was a 35-weeker. And so I do feel like my own personal experience with a late preterm infant, definitely helped shape my own professional practices and how I can relate to families. But and our passion, a lot of it is, of course, what we're going to talk about. No disclosures, but I do want to say that we will be throwing around terminology like, breastfeeding parent, lactating parent, mama, mother. We really do mean to use these interchangeably just for practical purposes, but we do want to remain mindful, especially with working with specific families. We have a very diverse population in terms of our terminology. Same also with the terms breastfeeding and chest feeding as well. So these are our hospitals at UC San Diego. The top one, that's Jacobs. That's where we work. Just a little bit of background here. I am the full-time lead NICU OT, and we also have another full-time NICU occupational therapist. We also have 2 part-time and 1 PRN, for a total of 5 of us. We all have at least a lactation counselor certification and up to IBCLC. That's a requirement to work in our NICU. And we are also all swallowing evaluation, assessment, and treatment certified to do swallow studies and things like that. And we are hoping to add in fees soon so we can assess breastfeeding. Anyway, the big point I want to make here is that we start 5 a.m., sometimes 4 a.m. Like yesterday, I started at 4 a.m. because, a fair number of our parents, if they're working or they have children, they stay overnight and they're here overnight and they come late into the evening after typically we would go home. And so also we can really get to know our night shift staff. So this program, as well as other programs that we have started, I found it is a huge part of how we can get our programs to sustain and for buy-in, because I can have a conversation with a night nurse that's pretty skeptical at 4:30 a.m. or 6 a.m. that I wouldn't otherwise see if I had other hours. And it's just really helped unify the whole team, because really working with babies, the night shift, they're doing half of the, exactly half of the plan of care, yet they almost would otherwise not see OT on a day schedule. And then, of course, our Jacobs Medical Center is 52 beds, level 3. And then we do have another NICU that's a 16-bed, level 2.
Yeah, and Hillcrest was the one where the NICU used to be before we moved into our new building, which used to be, I worked there, both Eric and I, that old ward NICU that everyone was all around. So it's been interesting, going from that to we have separate rooms for each baby and parent. And then so for me, lactation, we have 2 full-time. I used to be one of the only full-times, and now we hired one of our nurses who's wonderful. She was a grad nurse there. She was hired and worked there her whole career and now became a lactation consultant. And I just love having work with her. She works evenings. So I work like 8 to 5:30, and then she works like 12 to, we're a little flexible. It's about 12 to 9, 12 to 9:30. We work 9-hour days. And then we have a per diem lactation consultant. And then 2 of our NICU nurses work occasionally as lactation consultants. So we try to have 2 on. It hasn't happened lately. It depends on our census, but that's been wonderful. I mean, adding that on. And again, we have a lot of coverage for this. So our lactation is one of the most important things in our NICU between OT lactation. The parents definitely are coming to UCSD for the lactation services also. So.
So Ruth and I, we co-chair our program SPIN, which stands for Supporting Premature Infant Nutrition. But this is like a multidisciplinary group. We'll go into that in a little bit. Our mission statement, I just want to mention here, you guys can read it, but it used to be different. It was started in 2008, and it had a slightly different mission statement, definitely still focused on breast milk, human milk provision, but didn't mention safe feeding practices or positive engagement, because, it's not only what we're feeding them, but how we're feeding them, and put all the pieces together in terms of techniques and monitoring infant cues and behaviors and empowering parents. When do we start feeding? When do we stop feeding? All of those things. And so we updated our mission statement to reflect that.
And so the SPIN program started, and you all might have heard of them, Dr. Jay Kim and Dr. Lisa Stahlwagen. They're the ones that are the pioneers of the SPIN program. And that was launched in March in 2008. And the big reasons for it was that we wanted to prevent the neck enterocolitis, and also wanted to make sure that we had breast milk. Because before that, the maximum human milk exposure wasn't there. And so they started this program, which definitely has changed everything about what we've done. Our neck rates are very minimal, if none. And of course, we'll go on into more of how the program has changed. One of the main issues, and we'll talk about it later, but one of the main issues that we love to have is we got loaner breast pumps. So our moms of little tiny babies get some loaner symphonies. And I think that is one of the biggest issues that's helped our mothers bring in more human milk. And then these are the SPIN program 10 steps. As you see, more collaboration between nutrition, lactation, and OT. As Erica mentioned, in the past, it was pretty much about lactation and breast milk, and as well as making better nutrition modules, and we'll talk about that later. But if you know the baby, the 10 steps, we kind of did the same thing here, the spin program 10 steps, and we're very good at following them. We even have an outpatient lactation clinic, and we'll go into that more later. But we just wanted to give you an overview of the wonderful spin program. Many of you have heard of it, and we're continuing to practice that. And I feel very blessed that, Eric and I can be in co-chairs of that, and we have great team. I mean, it's up to the point where sometimes we meet, sometimes we don't, because we just have everything going well. And we just have to add little issues that come up here and there. So we're really blessed to have this spin program and continue to follow in the tradition of the starting and being able to continue it. So and then this one is going on about the baby friendly. One thing we are baby friendly, so we do follow the baby friendly requirements. So everyone right now gets 20 hours of breastfeeding education. We have a program. The way we're doing it is going to be changing. We're going to continue to do this. All staff gets 20 hours as lactation and OT. They're starting to follow both of us. So the NICU nurses will come follow us for about 6 hours, and usually we'll share that with OT because it's such an integral part of the breastfeeding journey. We have breast pumps, Symphony breast pumps in every room in the NICU and in post. So women and infants is labor, delivery, postpartum, and the NICU. So we have breast pumps in every room. We also, again, have the loaner pumps, so we get our moms who our babies are under 1,000 grams. And then we have gift shop rentals, so they can rent from the gift shop, or we can help with the rentals. Everything's online, they pay for it. And then we have really good collection, storage, and transport. If you go online, there's an article from Dr. Stahlwagen about storing and transporting our breast milk. We allow combining and pooling, and we allow, again, following the guidelines now of breast milk fresh for 4 days. So we have a really good handout that we hand out, and we just have milk techs. We'll go into more of that, like the milk prep room. So we have very good continual process of how our babies receive the milk from beginning to feeding. And we have milk scanning systems, so the mom system, so everything is logged in. And it's really good when moms bring it in, we can log it in, we can see how much volume we have. And that's part of a collaboration. The dietitian will say, hey, it looks like mom doesn't have any in the unit, but I can see that mom has a 24-hour milk volume of 500, what's going on? So again, we're in the same office, but we also have this as part of our documentation. So we're able to see that. The nurses have to scan it. They're great with it. And yes, we have the milk techs who make the milk and make all the syringes. It's one thing the nurses do not have to do. It makes a huge difference because the nurses then have more time for patient care and for assisting with lactation. Of course, we have nipple shields, we have flange sizing, we have massage with oil. Eric can talk more about that. But, we have all the resources our parents need. We give them all the supplies, this cooler bag that we give them. It's a nice advertisement also. So we take care of that. And then we have a providing rounding tool. When we were doing this whole project, one of them I was getting them when they round during the day, in the morning, the doc, that they would have a rounding tool that said how much milk volume mom had, where's the baby in their feeding, how much milk, again, mom has, is baby going to breast? And it's been really helpful with this rounding tool. It's also in the resident manual, and we do teaching, Eric and I, every year for the fellows. Residents, not so much in their manual, but the fellows, we do a teaching every year for them just to go over lactation. And again, our collaborative program that we have. And everyone knows the importance of breastfeeding and breast milk in our unit. And then we collaborate with postpartum. Erica can talk more about that, but postpartum has their own lactation and NICU has separate. We are very collaborative, but we do separate. But Erica and the team as OT do both, so she can talk more about that. And then, of course, as Claire and I met at the HMI Human Milk Institute, there are a lot of our research components. So UCSD is from research to actual practical feeding. A lot of our doctors do research on breast milk. We have that. We could go into a whole talk on itself of the research that we have. We have great research here. So. This is use of pasteurized donor milk. Part of this whole process was starting, as you all heard of, the University of California Health Milk Bank. It's now here from UC Health. We're very excited to have this milk bank. We use donor milk if mom doesn't have enough milk or doesn't choose to pump or breastfeed, which is very unusual. Premature infants all up to 34 weeks. And we also bridge the gap. So not everyone has this. We're blessed to use donor milk for all of our babies. So our late pretermers and our term babies, it's called bridge milk. We kind of bridge the gaps until mom's able to increase her milk supply. And we use donor milk. It's flexible. Postpartum, sometimes we do it longer. In the NICU, we do it longer. If it's a mom who's not in the long run going to breastfeed, a lot of times we'll do it shorter just to coat that gut. So we have, of course, a lot of access to the donor milk. We also have take-home packs in postpartum. They do it in the NICU also. So let's say a baby's short-term in the NICU for hyperbilly, parents can purchase take-home packs to go home. So we have that option. It's, again, all online, QR codes, and then we just hand it to them once it's paid. We do verbal consent for donor milk. We used to do where it had the sign, but we don't do that anymore. They're handed a parent handout and their verbal consent. And I'd say 99% of people approve it. I'd say now and then, depending on culture, they don't, or later on, I'll find out it wasn't explained very well. And once I explain it, they're very happy to use it. We just document it and then, yeah, parent consent. So any person in the hospital, in the unit can do it. It used to be docs. Now any person can give that information. So we do use that also.
And then we do have 3 dietitians who really closely follow our babies. We do use standard IEPs. Some of you may have heard of that, but basically by age and weight, determining the parenteral and enteral nutrition. We also use the Keller growth velocity tables for preterm infants. Jacqueline Keller, she was our lead dietitian until recently when she retired. And so we do track growth velocity that helps determine, plans. And of course, looking at those growth percentiles and Z-scores, we use the Fenton, of course, for premature infants and the WHO for term. And then, of course, closely tracking labs. And for standard, it's like once a week for your standard preemie, sometimes longer for more stable term, post-term kiddos. And then, of course, much more frequently for kids that, for example, that need TPN. The other thing that we do for our fortification for discharge is that we use premature infant PE 30 cal formula to 3 to 4 ounces depending on the baby's needs, and then the rest, of course, is mama's breast milk. And if the mama does not have enough, then we end up doing like half and half of a lower cal premature formula and breast milk. But the reason that we use the 30 cal is so we can, if the parent has a really good milk supply, adequate milk supply that way, or even a little close, because even if it's off by these 3 or 4 ounces, it is just less formula going in. And
it's optimizing breastfeeding, and the breast milk. It makes a big difference. And this is they only get 1 ounce 3 to 4 times a day. And if not, then they'll do EmphaCare. But we really maximize the breast milk while we're using the extra calories for these premature babies.
Yeah. And they usually only do that for about a month or so, usually is all they do. So this is essentially our workflow with our babies in the NICU as they are admitted. And what we're going to talk about is wee nuzzle, which is why I put the little blue arrow there for our non-nutritive breastfeeding. But before I get to that, just a couple extra details. We're encouraging skin to skin from the beginning. And we actually did have a QI project on that recently as well. We also do neonatal oral care, oral hygiene, and milk drops for oral enjoyment. The drops start at day of life 1, going into the buccal pads, 0.2 mLs, and of course for gut immunity. And then after the first 7 days, we transition to drops. Again, that's a whole other thing. Wee nuzzle, which is we're going to talk about today, that starts for us at 30 weeks. And nutritive breastfeeding for us in our NICU starts at 32 weeks, unless they're in a respiratory support level higher than 2 liters. I'm going to briefly touch on our oral feeding pathway, but we want to say that it is an oral feeding pathway. It's not a bottle feeding. And so everything we do with wee nuzzle is just really ramping up for these babies to nutritively breastfeed. And so most of our babies are just breastfeeding nutritively between 32 and 34 weeks, because most of our babies aren't queuing enough or ready for bottles. And so usually bottles start around 34 weeks or so. But really the modality is just we want to really make parents comfortable with breast before bottle. And it's just give them a much better sort of running head start with this. And then our oral feeding pathway is RN driven. at the bedside. So there's no doctor. The doctors just write the order. The providers just write the order to start the pathway when the baby is ready and stable. And then the RNs drive this based on the baby's cues with occupational therapy and lactation guidance. Oh,
Erica always calls
yeah.
sometimes non-nutritive glorified skin to skin, more to help parents, because parents get still weird about breastfeeding. And I love when Erica says that, because it really helps the parents to go, oh, okay. And she's really taught me to say that also. Because they think, well, the baby can't breastfeed. Like, no, this is like at the breast, non-nutritive, glorified skin to skin. And they love it. The parents really understand that. So
yes, exactly. And then we have and then we just have a visual representation to help staff and family actually kind of picture what this looks like. Because we start in the beginning center with skin to skin, and then we add in milk drops. And then at 30 weeks, we add in we nuzzle, but you notice milk drops really can incorporate skin to skin because we want to offer those milk drops, especially if they're in skin to skin, they're right there. And then we nuzzle, if getting a couple drops, latching I'll get into that, but basically it's a pumped breast. And then once they get up to our oral feeding pathway we feeds, which is our breastfeeding bottle feeding pathway, we're still incorporating skin to skin. They're still getting milk drops when they're not, practicing PO, and they're still getting we nuzzle on those off times. And so it really just kind of encompasses as the baby's skill and developmental abilities improve. And then all this is done in this whole background, this whole environment of all these other supportive practices going on. And which is, of course, more than this, but it just gives you the idea that this family, these parents, this baby, they really do have a cocoon of support. And just trying to advocate, that we can do everything as optimally as possible on our end as staff to help promote these things, just really to support the family and the baby so they can go home as safely and as soon as possible.
And if you've seen a theme, if you've seen a theme, we have we reads, we nuzzle, and we feed. So just so you know, we have a really good we theme here that we love.
I know. Really I don't even know. Is anyone even Irish? Yeah, I don't even know. But
we love it.
That's kind of how it went. And then this is our we feed oral feeding pathway, which is just really automatically started for babies under 34 weeks. But we do use it for any baby with feeding difficulties. If we're trying them out, per cues or what have you, and they're really struggling, then we can also go and we can also put them on this pathway anywhere on it. And a lot of our babies, even older, do ultimately get on this pathway, and they do get out of here faster. So as you see, the provider order to begin, and then I have circled where, if they're not ready for oral feeding at or above 32 weeks, then we're going to be continuing to do many things, including put to your prompt breast for we nuzzle. And this is basically just a stage stair step pathway. So to the meat of what we want to talk about, we nuzzle. So the background here is, years ago, I've been at UCSD since 2013. And I noticed that really non-nutritive breastfeeding really wasn't happening like at all. There was this idea that babies would tire out or it's not safe or things like that. Staff and in general, staff and families alike were kind of skittish. And so I did talk to our medical director at the time and all the faculty and said, okay, what would really help is knowing what faculty would be comfortable with, at what age level would they be able to safely go to breast. Obviously not intubated, but really with all the other levels of respiratory support if they're otherwise stable. And our providers agreed on 30 weeks. So, but still, even with this 30-week definite parameter, and we were still calling it non-nutritive breastfeeding. And I think because feeding and breastfeeding are in the title, it was daunting to a lot of people. And of course, we weren't talking about it. It wasn't necessarily seen as a value, or, because nutrition wasn't being exchanged in. I think people just would kind of forget about it. And so if we don't talk about it, if we don't make it its own goal, then people would forget. And we didn't document on it either in Epic. And then, of course, the classic issue of even having parents available. But all this was leading to, decreased non-nutritive breastfeeding. We had decreased breastfeeding. I would be getting a lot of consults where it's like, baby's ready to PO, can OT assess? And baby had never been to breast. And that, they'd be maybe like 35 weeks or something. And the parents, they have breast milk, they have a full supply of breast milk, which of course is the issue where it's like, yes, baby has breast milk pumped, but yet this baby, even if mother is able and willing and present, they were never having an opportunity to breastfeed. So then I'm like, okay, well, forget this bottle feeding order. We're going to do breastfeeding, and we'll get to bottle feeding later. And so we wanted to, again, back this up to this 30-week goal we had.
We used to have dolls that we practiced with. A lactation before me had dolls, and it's really nice as we continued on. We didn't use dolls, we used the real babies. And so that was kind of where it was before. We'd practice, but they'd get to 35 weeks and still hadn't actually put their baby to breast. So yeah.
Exactly.
And what is we know, so I mean, we really went over it, but we're going to go real quick. Non-nutritive breastfeeding, going to a pumped breast. And I don't, a drained breast. I don't like to say empty breast. I tell parents you're drained, and they're still going to get drops. This is where they're going to get their milk drops from. They're going to get it from the breast. And I do have moms who've already pumped, go ahead and use some of those drops from their breast. We do sometimes the milk drops can be from their tube. So we're trying to get wee nozzle while they're getting their tube feed. It's skin to skin, it's that like glorified skin to skin. I tell parents if they're rooting, you can put them there. Again, drained, pumped infant on the chest or breast. It's kind of sometimes their mouth is just sitting there. They're not doing much, as we tell, they're pre-feeding. They're using their tongue, they're licking and lapping. And I tell parents that's amazing. We call it taste or little sucks. They're exploring the areolar nipple, and they may or may not latch. I don't worry about latching as much in this. And Eric and I, when they're doing this, are they there? Are they there at the breast? Sometimes I'll get them latched, mom will, or we'll use a nipple shield, but not really. This is just for practice and play and pre-feeding and milk drops. So parents are really starting to really enjoy it and do it more.
So coming now to basically our practice, like we said, starts at 30 weeks, and we can use it on all different levels of respiratory support, except for obviously when they're intubated. And again, as Ruth has stated, many of the benefits, I would say, honestly, the biggest benefit we have seen to this is just getting parents comfortable. Like they're bringing these babies to breasts that are little. They're definitely more fragile. They're, have more lines and tubes and all these things. And parents are getting comfortable with, we do practice the standing parent transfer, which is where we teach parents to be independent with staff monitoring lines, making sure the chair is behind them, that they stand and they take the baby out themselves, and to minimize stress, both for the baby and the parent and the staff, actually, versus, this dangling sort of floating in the air transfer that we used to do with parents sitting at bedside. Again, to empower independence for parents and feel more comfortable, because what we do see is that if they feel comfortable handling and managing and getting a tiny little baby with all this other respiratory support to breast, they just get, parents themselves, they just get used to the handling and, oh, what my baby looks like, and oh, when they're awake, and oh, when they're rooting, and oh, when they're stressed. And so by the time they get to the age where they can breastfeed, these babies are just like ahead of the game, and the parents are already so comfortable because now their baby's bigger, there's less lines and tubes, they're so much more stable. Like it's a very fluid growth process, and it really organically makes the whole process so much easier for everybody involved.
And for us too, because parents are very involved. They don't need, we're there to assist them, but they're really able to we even teach them to do the pre and post weights themselves. So it's really getting that autonomy for the parent. It makes a big difference.
For our actual QI team. So as I was saying before, we were struggling with having non-nutritive breastfeeding, actually working in the NICU, though we all determined the 30 weeks mark was good. And then we had a couple of fellows, Dr. Barnard and Dr. Focus Escalante. They were wonderful they were motivated for this. They needed a project and they were interested in this. So they were wonderful really to come to spin. They were interested in this, and all of us together, we decided to make this what we want to study, and to really try to promote on the unit. And so again, the eligibility was the same at 30 weeks. And again, on various levels of respiratory support, or room-air, but not intubated, and no UACs, no sort of major instabilities or congenital issues. And the difference with this study that we don't currently practice in the unit, but just for the sake of getting rid of extraneous factors, is for this QI project, we made sure that babies that participated were not actually eligible for nutritive breastfeeding. So that means they might have been over 32 weeks, but they were on respiratory support, or perhaps, enterally they weren't tolerating their food so well. So maybe they were on 60-minute gavage feeds and not really ready for oral feeding yet, or whatever the case may be. But in our practice in our unit today, we definitely, even if babies are eligible for nutritive breastfeeding and they are breastfeeding maybe once or twice a day, at other times, parents absolutely, when the baby is gavaging, or what have you, they can bring their baby to a pumped breast if they like. So our SMART aim we did the PDSA cycles to measure all this. Our SMART aim was for a year. We wanted to see if we could cut our timeline from when a baby is first born to when they go to nutritive breastfeeding, if we can cut that by 50%. So from 2 weeks to 1 week. And all of our babies were under 34 weeks that we brought into this study, as they were likely to be the ones that were not eligible for nutritively breastfeeding, but just to have a younger age. And then, so they could have been a 25-weeker, but but at 30 weeks is when we would start data collecting for the non-nutritive breastfeeding piece. And our global aim overall was just to increase the provision of breast milk and breastfeeding at discharge for preterm infants. And of course, if you notice the date, this is back during COVID days. We do have some stats at the end to show you in terms of our numbers, but obviously things took a dive during COVID. And, already even before COVID, though we weren't tracking this, we could see it wasn't sticking and it wasn't great. So we wanted to increase. So our balancing measures were essentially the percentage of infants who had an increase in their respiratory support within 3 days after a non-nutritive breastfeeding session. Ostensibly that they had a negative response, maybe aspirated a little bit or something like that, just because that's essentially everyone's fear going into this. And out of 113 infants, they only one had this happen to them, and they only went from room-air to 1 liter. And now it was 24 hours after that session. And, was that a direct cause? Was it related? Was it totally unrelated? Because, once in a while, babies do need to go back up. We don't know, but that's what we have. And then our process measure that we looked at was we had a SMART phrase or any sort of mention of we nuzzle. Oh, and I want to mention too, the name we nuzzle. So remember how I said how, we just got the sense that because breastfeeding was in the title, even though non-nutritive was before it, and then it also kind of sounds so cold and textbook, non-nutritive breastfeeding. Also, it's a mouthful to say. So we decided to come up with a different name that sounded cute and more cuddly and less threatening, and also that did not have the word feeding in it. And so we decided on we nuzzle, because we nuzzle seems, a baby nuzzling at a nipple, and even babies nuzzle in during skin to skin. So again, this was just a small step. So that's where that name came from. So with this we nuzzle name, we designed an epic SMART phrase, for the doctor's practice notes. And we wanted to see if this is working, if all the providers, our NNPs and our physicians, are they putting this in their note, which was part of the goal. And at the end, 90% did have the SMART phrase or remnant. And then 60% did have the correct information within the SMART phrase. So progress from essentially zero.
And then, we had our key driver key drivers, and this is the diagram that we did. Our global aim. What are the primary drivers? Why were we doing this? What were the secondary drivers? And then what were the change ideas that we accomplished? So this was a really good visual picture of what, and a lot of times with projects, you want to use this. And this was a part of the quality initiative was our key driver aim.
This is essentially what the results were. Ultimately, we had a 62% decrease in days from first non-nutritive breastfeed for infants born under 34 weeks. So essentially, the mean time was, roughly we were hoping to drop from about 2 weeks down to 1 week. So essentially, it was a mean of 13.9 to 5.2, and we had 3 different PDSA cycles. We started out first with the skills fair, OT and lactation. We did all the skills fairs for that time period, just introduced all this concept. We had email postings, we had postings around the unit so people knew what was going on. And then we ended up incorporating our provider rounding tool, the smart phrase into the daily, the provider's daily note. And then finally, the last cycle, just a month later in August 2021, we added an admission order. So essentially what was happening is still people, when those babies went to 30 weeks, nurses would forget, doctors would forget. I mean, lactation and OT were on it, but we can't be there all the time. And so we decided to make it an automatic admission order that they just have it. So there's no need to think about it or have to ask for the order and all that kind of stuff, that it would be there and it'll be part of our standard of care.
I was going to say, just to add that, I've gotten so used to it that I think one day I helped put a baby to non-nutritive wee nuzzle and I'm like, oh, you're 29 weeks. Oh, well, but the baby did so good. Like, it's just such a normal for us to do it. And it was just a wonderful practice that we finally got into. I didn't even think about the order or what we're doing. It was just a part of what I wanted to do with mom, and it was fine. But so some of the challenges implementing wee nuzzle, the change in a unit's culture, and kind of Erica mentioned it. People always thought of it as they're going to get milk, they're going to aspirate. And we really had to clarify this is, non-nutritive. They're going to breast. They're not going to get, hopefully, lots of feeds, and, they're buying and consistent, their understanding of what non-nutritive was. And like Erica said, it's a daily discussion, the medical chart. I mean, and then we have an academic unit, so we have a lot of people coming in and out. We have the residents who are training coming in and out. We have a lot of traveling nurses, especially at the time, not so much now, but a lot of different nurses from different hospitals and different, units where hadn't done this before. Again, that same mentality of they can't go to breast, or they're going to get too tired. And that's the big one we've had to really work through, is they're not tired if they're sitting there on the breast while they're getting their nutrition. And that was a big, I think, aspect of explaining. Everyone thinks you only go to breast once or twice, you're too tired. Well, they're not. There's a difference of going to breast and there's a difference of breastfeeding. And that has really made a big impact. And the other challenge is we do have parents from other areas. So we're in San Diego, we get people from Temecula, 45 minutes away, Menifee, Calexico, El Centro. So a lot of it is transportation, language. We have a lot of Spanish speakers, of course, but other ones, and sometimes just making sure they're understanding what's going on and being there, and making sure that we have translation and we're talking to the parents of other languages just like everyone else. And just culture. Some cultures have different, and we have kind of the opposite. They want to put the babies to breast culturally, but they don't pump. And so then we don't have milk for the baby. So that's, I think, a bunch of the challenges that we've had at the time that I can think of. And again, going to breast, I caught a lot. You're going to breast, glorified skin to skin. Changing the wording has really made a difference. But this was the challenge before that in our culture. So, and all our neonatologists are on board now. I mean, it's been an amazing change, and we'll talk about that more later.
This was a poster that our fellows, they did make this. They've, I think, presented at several different conferences, just discussing, with our key driver, our fishbone diagram, and then our PDSA, our control chart with our information. And then I didn't mention, but in terms of our global aim was to increase breast milk provision. So we started out, it was like about 59%, and it went up to 72% at the time of their statistical analysis. So I have a few different charts here. So looking at that time, you can see in 2021, ultimately it took a dive this is for breast milk feeding rate. So this is just breast milk at discharge, which babies went home and that had a breast milk supply. And you can see in 2021, it went up and then tanked. Of course, that was Omicron. And then we ended up increasing it then slowly over 22, 23. And then 23, 24, we essentially are back up, sometimes hitting into the low 90s. And there's been obviously hits and misses at different times. And then this is now 2025 with the yellow line. So we're out of like the lower numbers for sure. I mean, we'll hit 70s once in a while, but mostly 80s and even getting up into the mid 90s sometimes. So we're just tracking this, seeing what, we can do more, what we can do better. I do want to say for our nutritive breastfeeding sessions, this doesn't really say too much. So this is not non-nutritive, this is nutritive now. We've really stabilized out because we did not track this for a long time before, but we have about a little over 3/4 of our moms getting breastfeeding sessions. And I probably should have put the frequency on here because most of these moms are doing it 20, 30, 40 times. I mean, they're coming in frequently or they're there a long time, but we're in the double digits with how many breastfeeding sessions they're doing. Many times they're doing it every day. So that's one thing we want to do is just get more accurate and pinpoint all of our tracking, which was a really great thing, I have to say, to have these fellows to want to do this project, because as lactation and OT, it is really hard for us to do QI, and I think for ancillary staff in general, nurses, any sort of bedside staff, I feel like it gets really tough for us to do this because this is not really built into our job description per se, or do we have the time? It's like I have to be productive. So it's just like in terms of my hours and everything. So I do feel like it's helpful when we have this whole team of everybody, So for the We Nuzzle QI project plus the just spin in general, we have, providers, we have respiratory therapists, we have social workers, we have dietitians, OT, lactation, as I said, nurses, of course, are crucial, nurse educators. And then also we have NICU grad parents that are kind of ad hoc. And we had a great couple parent reps for us for this QI project too. Mm-hmm. So it really takes all of us. And so we all have different talents, so OT, lactation, nursing, we're out there, working with these parents in the trenches every day. But again, it really took, I feel like, these fellows to come in to start bringing this to provider level, that we have the terminology, that we have the awareness in their daily rounds. So if the providers are talking about it in rounds with nursing and parents, everyone's more likely to pay attention and address it. And it just really takes the whole team. RTs, I can't even tell you, when we were doing all this education for our standing parent transfer training, and especially with our higher level of support. And again, of course, on a separate subject with just skin to skin in general, to get our babies that, are on jets or oscillators or intubated in general, just to skin. RTs are such a crucial piece of that. And so when you had RTs like cheering on and ready to help to get a baby to, make sure mama can do her standing parent transfer so she can go into breast to do We Nuzzle, like that's pretty cool that we're that interdisciplinary focus.
Just wanted to add to, we're not talking about lactation as much with the We Nuzzle, of course, going to breast, but we do a lot of pumping support with parents, and we believe pumping is 6 to 8 times a day. And we really keep an eye on mom's 24 hours milk volume. We want them to document it. And so we've seen the increase in this, them they're being on top of their pumping and their breast milk, and seeing once the babies can go to breast, how much they're transferring test weights because they've been practicing this. And mom has a good milk supply. It's just amazing to see that baby can breastfeed and mom has milk, which makes it so much easier for these babies to actually take from non-nutritive wee nuzzle to breastfeeding. And it just, you just see the difference in it. And moms, we have moms, we probably should start keeping track of the moms who have such a good milk supply. I think that would be another good project to have. We're really working, Celeste at the lactation, working with her CN3 project is going to be help moms with those larger milk supplies donate milk to the milk bank. So we've been, again, we're helping these moms keep their milk. It's for their babies, but when you have excessive amount, also helping them to the milk bank. And a lot of these parents love it because they receive donor milk at the beginning and they really want to give back. So from a lactation standpoint, we're just constantly there with the milk supply, supporting the parents, helping them put the babies to breast. We actually make appointments in the NICU. So we have lactation appointments when parents come so they know when to come so we can do feeds. And again, the OT helps with breastfeeding. If they're OT, we help with breastfeeding, but I'm pretty good at bottle feeding too if I need to with parents. That's important for lactation consultants to know also. So our next steps, continued education of the parents and staff, just what we were talking about. Keep document it, making sure it's still in the documentation. The nurses put in, or I do I document like a nurse at the bedside. So once we put baby to wee nuzzle, we put it in the INO, wee nuzzle, and then I actually document that the baby went to wee nuzzle in my note. And then keep working on that terminology. It's become standard, I think, in our unit, and just the new ones we need to teach. There is a process of the holding committee, because in the past for holding skin to skin, they wouldn't want those babies. It took a while with the intubated. I also feel like we're doing much better with the intubated babies. I say the harder part has been the EEG. A lot of them don't want to move the babies who are on EEG just because sometimes their leads will come off. But we've talked with neurology, and they're having no problem with mom doing her normal process of placing the baby to breast or skin to skin. So we're more going towards that also. So this is a wonderful project that they're working on, the holding committee. And I also am working, I already spoke to Claire and speak to on the antepartum education. Is we have a lot of parents who are here in-house and they're not getting any education before they have their baby. They're here at 32 weeks, 34 weeks. And we really could discuss with them before they come to the NICU and have a lot of this education before, which I would like to keep track of the breastfeeding, breast milk rates with this. So that is my next step on the antepartum. And Erica, do you want to talk about your clinic there?
Oh, yeah. So we have, I actually presented it to like the CNO and all the top UC administration. I did a PDSA sort of proposal to open up it started out as an interdisciplinary, developmental clinic, but then just to get in the door, I feel like most pertinent right now is like an outpatient feeding clinic. And everyone was like on board. And then, of course, and it was just not a matter of if this would happen, it was when. And then getting all those ducks in a row. And of course, that's when COVID hit. And so several years later now, we still definitely have a need, especially for helping our families. They're breastfeeding. They're maybe taking 1 or 2 full breastfeedings a day, and they're otherwise supplementing with bottles, and like kind of getting them to integrate more breastfeeding. And how do they evolve? How do they get to that next point? Especially if sometimes parents are nervous, or if there's like, weight loss issues that they're concerned about or what have you. So just having an outpatient touch point for them with clinicians that they already know, that know their child. And also that could serve the community as a whole. So this would be an outpatient, OT lactation feeding clinic, which with dietitians ad hoc. Obviously, as OT to do outpatient, we're in communication with the pediatricians or specialists, depending on the situation. And so whether it's kids that were aspirating, that had to end up going on thickener, that were working on integrating more breastfeeding, that had oral aversion, if it's just parents wanting a little bit more education, maybe, there's other things going on. So now essentially what we're looking at is opening in fall of 2025. So we already have everything. We have our hospital breastfeeding scale. We have all our supplies purchased and ready to go. And actually, when I started, it was myself, and then we had one PRN OT that they'd let work once or twice a week, just depending. So it was very bare bones staff when I started as OT. And, we've hired and built this program more now just because of the need. And now that we actually have more OT staff, we can cross cover a feeding clinic. And then ultimately, too, our faculty is looking into NG to home programs, but that's another talk.
And then for lactation, we have our breastfeed. It used to be called the Premature Infant Nutrition Clinic, which was PINK. That's when SPIN started. That's one of the issues they found in SPIN was you could do really well in the hospital, but what did you do when they went home? So it's now called the Breastfeeding and Lactation Medicine Clinic. It's run pretty much by UCSD Pediatrics, and a few of the doctors, the pediatricians, are lactation consultants. So they're able to bill. So we definitely refer to them for all of our babies, preemies especially. And then our Rady's Children's System has CPCMG. They also have lactation consultants. And we have a really good, San Diego Breastfeeding Coalition. So there's so many resources that we have, and private in our community. So we refer a lot of parents. That's one of my priorities is once they're discharged, we go over the whole discharge plan, what they're feeding with, what bottles, what nipples, where are they going for lactation. We know breast NICU babies need to be breast and bottle a lot of times to do both, but we're really encouraging them most parents want to do breastfeeding in the long run. So we're really excited for all of these opportunities that we have to move forward. I think that's it.
Yeah, that's it.
Process,
Does anyone
please.
have any questions?
Oh my goodness, this is so inspiring and amazing. Thank you so much for sharing. I'm going to pause the recording, and then if anybody has a question, please feel free to come off